Well, thanks. So Bob set that up pretty nicely for me to do a bit of a deeper dive. So this may be of interest to some. I think to Branji's point, part of the goal is just to establish this as a model of feasibility of care. The scale of this here, this was designed to solve Michigan problems. In terms of the scale we built it at, the actual concept may be scaled down in other places or may look a little bit different. We certainly, since we've opened this 2 years ago, and I'll show you some of the data, have had quite a bit of interest from around the country at different levels of how it might apply to different patient populations in different settings. And I think we also kind of built it to be a scalable model. So if you had all dual boarded EM intensivists, the only people who could work there, trying to scale that to a smaller place or someplace with less resources might be challenging. So we try to build it intentionally so it might be scalable. I got everybody at the top of their insulin secretion curve probably after lunch, so try to bear with. But as Bob mentioned, it's really a kind of the tripartite typical academic mission. EC3 gives us the platform to do all of those things. I'm going to focus mostly just kind of on the patient care operations of how we built it and how it works, and then some early results from the first 2 years. So this kind of flow shouldn't be, to most people in the room, is probably, at least the ED physicians should look pretty familiar of kind of our flow of our daily lives as the patients kind of enter the health system through the ED. And again, this is somewhat simplistic, but essentially people come in from any variety of sources, whether it's an EMS transfer from home or as a referral, as a big tertiary coordinator referral center. We get lots of referrals, obviously. They'll enter the ED. In the ED, we obviously will do our diagnostics, our workups to decide where they need to go from there, whether they can go home. If they need to come in the hospital, then what level of care they need. And then frequently they'll exit the hospital, and then unfortunately many will then re-enter the health system at further points in their care. So this is not a new thing. Obviously it overlays well with the ACRU framework that Machines created of transitions of care, and there's lots of them. So to let you know, just kind of when Dr. Newmar came in 2012 from Penn, with this as kind of his vision, this emergency medicine, critical care merging and providing critical care in the ED, some of the data we were starting with was to, like he said, was this really happening at Michigan? And how bad was it, or what was the scale of problems? And so just taking each one of these kind of points of transitions of care and looking at some of our data from 2012 when we started the journey, I'll just share with you quickly. So in terms of people coming into the health system or accessing our health system, that year we declined about 750 requests for ED to ED transfers because of capacity issues mostly, and ICU availability about 25% of those. So even accessing our health system through the ED was turned away at certain points. In terms of in the ED itself, when you have critically ill people, as you know, if you're not really built for it, which most of us have a resuscitation space or a place to care for these patients, but it's not made to care for them for 6, 8, 12 hours. It consumes massive amounts of resources. And being that these patients, although super sick, are probably the smallest denominator of your overall patients in the department at any one time, they consume a massive amount of resources and pull resources from the majority of your patients who are less ill but need the resources nonetheless. So there's a lot of shunting of resources. In that year, we admitted 450 patients to the unit, to any of the ICUs that never really touched our high resource spaces, our resuscitation bays, where we're staffed for these kind of patients, because we had too many of them and they stayed too long, and so our resources have to spread. And then once finally they're going to an ICU, now they're still sitting in the ER for, on average 6 hours, which again is tied to that increase in mortality. And then once they go to the unit, then we talked about ICU utilization in a place where ICU beds are extremely coveted. We run at 95% plus capacity at all times pretty much, or most of the time. And so when those spaces are coveted, how are you using them? And so that year, again, about 450 patients went to the units for less than 24 hours. And so you can argue, is that a good use of the space? Is there a different way to deliver that care more at the front end, where that ICU bed can be safe for somebody who's going to be there for 4 or 5 days and really need those resources for a longer term? And then there's the opposite problem when we admit people to the floor and then they emergently get transferred to the ICU in the middle of the night within 24 hours of ED admission. That's one of our peer review metrics. It's used by a lot of institutions. And we know there's also lots of studies which show you do worse. Your odds ratio of mortality and death is higher if you emergently are transferred to an ICU from the floor within 24 hours of ED admission. And then at discharge, and this is other concept of other people who come in critically ill who would have needed an ICU, but can we deliver that aggressive care early enough in their course? We actually can change their entire trajectory for disposition, and they could actually go home from the ED and never required admission of any level of care. So those were, for us, those were all kind of the roots of some of the things that we thought that this ED-ICU or EC3 might be able to impact at all levels of care. So again, Bob kind of shared our guiding principle with you of what we were trying to establish and what problems we were trying to solve at our institution. And again, I'm sure, I know from UCLA and from MGH, this is probably similar. Again, we talked about we have kind of an ICU for most disease processes and individualized, and they don't never really kind of come together, and they evolve because they're the extension of critical care for those specialties. So when neurosurgeons operate and they have somebody critically ill after surgery, they need a place for them to go. And those units, neuro ICUs develop so they can take care of those types of patients with special needs from those specialties. So they're developed from those in-house specialties backwards as opposed from the ED forwards. So really our model is to take these silos of critical care and really merge them, where the ED became the centerpiece, and then your care wasn't dependent on your geographic location in the health system or the hospital, but it was based on where you needed it, and it could be delivered at any point early enough where you needed that care. There wasn't a geographic specific location to get that care. So we opened in just a little over 2 years ago, the Emergency Critical Care Center. I'll show you a little video. It's just a little tour of kind of what the unit looks like. I'll give a caveat that it was really part of it as a snippet from a video that was designed for an architecture design competition. So there's a lot of references to design components. So you'll see that, but it does give you a good idea of a tour. You'll see everybody has orange stickers over their Michigan badges, and they're not proud of where they work. It was supposed to be so the judges were blinded to your institution. So just that caveat, I guess. The Emergency Critical Care Center, or the EC3, was designed to provide our critical care patients with continuous and seamless high-quality critical care right from the beginning. We were intentional about incorporating a lean-based design process into the design really from the earliest stages.
Our EMS entrance flows right into our resuscitation bays. Each resuscitation bay is equipped with a power boom and large monitors designed for 360-degree care around the patient. The monitors allow for the entire room of providers to see information on the patient at once. Each bay is also equipped with cameras to record patient care for quality assurance and team education. We provide dedicated teaching space within the resuscitation bays by installing digital whiteboards, which double as patient care monitors and allow for real-time education. Right outside of the resuscitation bays, a shelving unit was designed to hold infrequently used life-saving equipment that staff needs to have immediate access to in an emergency situation. Sliding glass doors offer staff the option of closing off space for crowd control, noise, temperature control, and isolation. Should a massive casualty incident take place, the doors can all be opened to allow one large patient care bay. From our resuscitation bays, there is a seamless transition into our Emergency Critical Care Center, offering our staff the ability to provide longitudinal critical care to our patients, continuing from the resuscitation bays into the EC3 and upstairs into the OR or general hospital. Each room was designed with the head of the bed clear from equipment to be sure nothing gets in the way of patient care.
To improve patient safety, we tried to centralize a nursing station, provider station, where we could all communicate together and also see across the entire area. A lab was centralized within the unit with double-sided access from the resuscitation bays and the EC3 rooms to allow for sample drop-off from both sides of the unit. Each room includes an electric bariatric lift to facilitate patient movement instead of causing physical harm to staff trying to move the patient on their own. Patient rooms were designed with natural light instead of the usual fluorescent lighting to help with healing. Artwork adds comfort for patients instead of stark white walls. We sacrificed designing more rooms to design bigger rooms with more space for everyone. The new rooms are larger than code requirements and provide space on one side for the caregiver and plenty of space on the other side for the patient's family or visitors. And most importantly, our new rooms provide comfort and privacy for our patients and their family members.
Our new Emergency Critical Care Center has been a labor of love from so many disciplines across the entire health system. We are very proud to have a unit that can provide the highest level of care and healing for our critically ill and injured patients.
So again, focused a lot of design things, but the idea was just to give you an idea of what the space looks like, and it doesn't really, you feel like you're in the ICU, not necessarily in the ER at that point. That used to be our old PEDS ED. So in terms of just the flow of how things work, so we are kind of a push system. All of our patients currently come in through the ED. They're seen by our primary ED teams. They're evaluated And then at some point, usually around the 90 to 120 minute mark, but sometimes shorter, sometimes longer, depending what the needs are, after kind of the initial diagnostics, therapeutic stabilizations procedures are done, then they'll consult the EC3 team, and then the patient will either be cared for in the resus bay by the EC3 team, or will get moved into EC3 itself, which is those 9 beds that Bob showed you that with the 5 resuscitation bays. In EC3, it just gives us a forum for time, essentially, right? It gives resources to the patient where we now can make decisions with more time. We have space, we have nursing, and the ability to do everything we need to do without really having to move the patient in multiple different places through the health system. It's a collaborative disposition. We'll have the ICU fellows and other people come down and evaluate the patients. It's not uncommon for somebody to start out medical and wind up surgical, things that happen lots of times upstairs previously, where you can make that disposition on the front end because you've had time to do the diagnostics, you follow their trends, their course, and see what happens. We have these pathways that Bob talked about, I'll show you in a minute, and then from EC3 really can go anywhere. We try not to get in the way of definitive care, so things we can't provide if somebody needs, if they need to go to the cath lab, they need interventional radiology, emergency in the operating room. We don't want to slow that process down, so those patients frequently still go from resus upstairs to definitive care. But from EC3, we then can, admit patients to the ICU, to 9 ICUs, send home, or palliative care, which I'll just show you some data on here in a minute. So pathways, we started out with 6 when we first opened 2 years ago. We've evolved into a lot more. 92% of our patients will wind up on an evidence-based kind of care pathway, which was again designed in conjunction with the inpatient ICUs. So it's kind of a continuum of care from the ED to upstairs. We can see evolved. A lot of those conditions are things you'd expect. Critical illness we see in the ED all the time. And then we have just developed some newer ones. Actually, other services have come to us actually asking, this is a great resource. Can we, this type of patient population we see all the time, is there a way we could start to take care of them down in EC3 and maybe change their trajectory for disposition? So we're rolling out a mild intracranial hemorrhage pathway from the neurosurgeons asked us to do that, acute severe pancreatitis, and then in line with our new ECPR study, a VA ECMO pathway for these patients after they are cannulated and go on in the ED. Frequently they will wind up in EC3 for 24 hours for ongoing care on ECMO, still in the ED. And then we do things that are a little bit atypical for the ED, but are things that are typical in the ICU. And again, we're trying to move that ICU care further forward in the patient's course. So every patient gets a chlorhexidine bath. They all get pressure dressing or dressings to avoid sacral decubitus ulcers. They get VT prophylaxis, vena-associated pneumonia or vent prophylaxis. We have a central line insertion checklist to reduce our CLABSI rates. So all these things that usually previously have been thought about as the inpatient side, we're starting to think about at the ED side. And so after 2 years, here's some results. So we average about 7 patients a day that come through EC3. The length of stay, the median length of stay for somebody who goes on from EC3 to an ICU is about 7 hours. And if you go on from EC3 to be able to be downgraded and no longer need an ICU admission, it's about a 12-hour stay. In terms of where patients go, so we've had about 5,600 patients come through the end of April. And where they go, so 31% will still go on to the ICUs from EC3. About 60% will be able to go to a non-ICU, so a floor or telemetry. About 9%, about 500 patients so far, will be able to go home from the ED ICU and never need an admission at all. And about 2% or 100 patients will expire in EC3, and many of those are end-of-life palliative care patients who come in extremis with advanced disease processes, who will, it's a kind of a planned withdrawal of care within the unit, so they never have to take an ICU bed or anywhere else, and the family can stay in one location. Or we can coordinate home hospice afterwards to be transferred directly from the ED ICU to home hospice in some cases. And in terms of this, over that kind of 2-year time period, keep in mind this as well, our ED volumes are going up about 4.5% overall, but about 10% of those are critical care warranted patients. So that's going up exponentially higher than our overall volumes going up year over year. But despite that, our ICU admissions, because of EC3, or a big part of that is because of EC3, have gone down quite a bit. So 17% overall reduction in ICU admissions. We exclude the trauma burn ICU because most of those patients go directly up to trauma burn from the ED and not come to EC3. But overall, year over year, we're seeing pretty impressive, or at least significant gains in ICU reduction or utilization for ICU admissions. And just looking as a percentage of overall ED admissions, that's a percentage of overall ED visits. This is overall ED admissions, again, going down year over year in the face of increasing volumes. And then just looking at where the patients go in terms of what units are impacted the most. So we have the ability probably to impact the medical ICUs the most. Obviously we don't operate, and so patients who need emergent surgeries we don't impact as much. But our biggest impact has been on our medical ICU, so about a 33% reduction in ICU utilization for the medical ICU since we opened. And so that creates a lot of capacity for them, and they're always under demand for those beds. And so it creates quite a bit of capacity for them to have those beds for other reasons. CCU, our cardiac ICU, also a pretty big impact. And all the units, the utilization has gone down, but the actual amount has varied and is more weighted towards the medical units. And then one of those metrics we looked at before is this kind of short-term ICU utilization for 24 hours or less after being admitted from the ED, and maybe there's a better way to use those beds. So since we've opened, we've reduced the amount of patients who are admitted to the ICU for less than 24 hours by a little over 40%. And then looking at 48-hour mortality, again, we want to make sure there's a safe strategy where we're not downgrading patients prematurely where they then go to the floor and do poorly, or have an increased mortality because of delivering this care earlier on in a non-traditionally designed ICU. And mortality really overall hasn't changed that much. It certainly has not gone up, just looking at 48-hour mortality in terms of very short term that may be impacted based on care we're providing. And then again, the downstream effect is that we're creating capacity for units upstairs which traditionally have no capacity. So now they can take more outside of ICU to ICU transfers directly into the ICU as opposed to having to turn those down previously. That's good for the health system, it's good for the patient, and their ability to respond to rapid responses on the floor, taking floor patients who decompensate into the units. They now have some more capacity to work with. So I'll finish there. So just kind of in conclusion, over 2 years of some early data, early results, things we've seen, this model of care, it's in this scale is fairly novel. It's the biggest in the country that we know of in terms of ED-based ICU. Certainly, I think has helped us accomplish that guiding principle of really moving critical care to really the front end of the patient's exposure to our health system. And by doing that, I think we're smoothing some of these transitions in care a little bit by having an area and resources and time to make some of these decisions and provide care in a traditional environment that didn't have that. We've been able to reduce ICU overall admissions without any sort of subsequent increase in Florida ICU admissions, emergent transfers, or 48-hour mortality. We've reduced short stay ICU admission utilization significantly by over 40%. And we've created upstairs capacity in a place which traditionally had no capacity to work with. And just as a caveat, obviously this is not an ED forced issue. You can't force this idea into a big health system. It has to be collaborative from the beginning, which it has been, and really has made it work by being collaborative with all the units and the health system from the very beginning when Bob drew the idea on the back of a napkin. To really make it work, you have to realize, you have to be able to do that as a health system approach that you're going to support this mission. It can't just be an ED specific agenda item. It will never work that way. So that's where we are after 2 years. We're still constantly evolving and developing, but that's some of our early kind of way we work and some of our early results. That's all I have. Yeah. Okay, good. Okay. Good. Any questions? I don't know how much time I have, but any questions?
It's fantastic, and the outcomes are really, really impressive. Can I ask a question about financing? Because it seems like a lot of added resource, and I don't probably see a revenue stream that increases with this. Is there any concern for the sustainability of this for funding? Or?
Yeah, I think they always have to obviously think about it. If you look at it just from a cost perspective, so the actual cost, so about 27% of our patients that we right now have a bit of a subjective system, but patients we earmark as critical. And the way we think of that as patients, if EC3 didn't exist, they would have had to go to an ICU, or at least an ICU being consulted. We've reduced those patients that come in at that critical level that now don't need an ICU anymore. It's down by about 27%. So those patients get out of the hospital 2 days earlier than they would have before. So there's a significant cost savings in that percentage of patients. So you're recouping some cost overall to the patient and the health system from that standpoint. It is a parallel staffing model, and it really requires critical care billing. So you have to sustain that you're putting the right patients there for the right reasons. We also build it flexible so that it doesn't have to have 9 critically ill patients in it. It's still ED space. It's still within our department. So we're constantly using those beds. So if we have people in the waiting room, there should be people in those beds. So, and because we're all ED physicians at base, whether we're dual boarded or not, we can take care of anybody who's in our waiting room. So we'll constantly backfill those beds with other patients so that space is not wasted and the nursing care that's provided is utilized. Okay, thank you.